Oi, pessoal, bem-vindos a mais um vídeo da série ABR Entrevista. Hoje a gente vai conversar com a professora Claire Hopkins, que é professora do King's College em Londres e publicou talvez um dos primeiros trabalhos importantes aí relacionando a anosmia com o Covid-19. So Claire, once again, thanks a lot in the name of the Brazilian ENT Association and the Brazilian Rhinological Association to agree to do this little interview with us.
It's a pleasure. It's nice to join you.
Professora Claire Hopkins, nos primeiros relatos sobre o Covid-19 na China, não se falava muito sobre anosmia, né? Como que você teve essa suspeita de que esses pacientes com Covid-19 tinham tão alta incidência de anosmia?
So I started to see patients presenting with isolated anosmia with no nasal obstruction in otherwise young, healthy people early in March. And 1 week in the middle of March, I had 9 patients in a row, all aged under 40, all with no nasal obstruction, no other symptoms. One patient had had some very mild flu-like symptoms a week before, and I started to wonder if it was related to COVID-19. At that point in London, we felt that we still had very few cases of COVID-19 and that they were only linked to travel from Italy or Iran. But certainly looking on discussion boards, particularly with the American Rhinologic Society, I realised that ENT colleagues all around the world were also starting to see very similar cases, particularly in Italy and Iran, where they already had quite a high incidence. And so at that point, we realised that as well as the severe cases that were being reported in hospital with fever, cough, shortness of breath, there were also a very large group of patients in the community with otherwise very mild symptoms, particularly with loss of sense of smell. And this was more common in the younger, otherwise healthy age group.
Aqui no Brasil, a gente tem visto bastante casos de anosmia também, inclusive a Associação Brasileira de Otorrino tem feito uma pesquisa com os otorrinos, tentando descobrir quais são as características clínicas da anosmia por Covid aqui no Brasil. Mas eu te pergunto como que é aí em Londres, nos seus casos, né? Quais são os principais aspectos clínicos da anosmia nesses pacientes? Ela é mais progressiva, ela é mais súbita? Normalmente é anosmia ou é só uma hiposmia? O que a senhora tem para dizer para a gente?
So what we're seeing is that it's typically very sudden in onset, going from normal sense of smell to really complete anosmia in a very short period of time. So patients are aware that suddenly they can't smell or taste their food at all. Mothers are describing how suddenly they can't smell their baby's nappy, or somebody was filling the car with petrol and realised they'd spilt the petrol but couldn't smell it at all. So it's a very dramatic onset. What's quite obvious in the majority of people is patients don't have a blocked nose, and they find that very odd. We've all seen cases of post-viral anosmia before, but in those cases, typically at the onset, patients have nasal congestion, a runny nose, therefore they're not surprised by the loss of sense of smell and taste. But with COVID-19, patients are very taken aback by the absence of other nasal symptoms. It seems to come on before other symptoms in about 1 in 5 patients, and in a small number remains as the only symptom. But in other patients, they typically develop other mild symptoms, for example, a burning pain in the nose, eye pain, muscle ache or fatigue in the days after the onset of loss of sense of smell.
É muito interessante, né, que os pacientes perdem o olfato sem ter outros sintomas nasosinusais associados. A senhora já chegou a ler alguma coisa ou tem alguma teoria, então, de qual é a real causa fisiopatológica dessa perda de olfato? É uma ação diretamente no nervo olfatório, no epitélio olfatório?
So there are 2 theories with regards to the underlying pathophysiology. One is that it might be related to inflammation in the nose. And we've shown in large studies, particularly working with the young otolaryngology group of IFOS, that although some patients report nasal obstruction, the severity of nasal obstruction isn't related to the severity of loss of smell. There's also been a suggestion by the group in Paris that it might be due to isolated inflammation in the olfactory cleft. So the patient doesn't report nasal obstruction, but the inflammation and edema in the olfactory cleft stops odours reaching the olfactory nerve endings. But again, with the young IFOS group, we've looked at CT scans in patients with recent onset anosmia. And although a small number have a pacification of the olfactory cleft, in most patients it seems to be clear. So we think that suggests that there's likely to be a central cause for the anosmia, that this is probably damage to the olfactory epithelium supporting cells, which are known to express the ACE, the angiotensin II receptor, or by direct invasion and damage to the olfactory bulb.
Uma das coisas que mais preocupam os pacientes quando eles nos procuram é saber se eles vão ou não melhorar do olfato, né? Então, eu gostaria de saber se existe algum aspecto clínico aí que indique se aquele paciente vai ter um melhor ou pior prognóstico da sua olfação.
Well, what we've seen so far is actually a significant number of patients recover quite quickly. And we've now got data looking at patients at 4 to 6 weeks. So still only relatively short term. But by that point, about 50% have resolved completely and now have a normal sense of smell. About 40% have shown some improvement, but about 10% have persistent loss and complete anosmia at 4 to 6 weeks out. The severity and the duration obviously give you some clue, but we haven't yet worked out what other features may predict a poor outcome in the longer term. What we need to do is follow these patients up moving forward, because we've got data from previously reported post-viral loss, but typically we only start to collect data on patients who have had loss of sense of smell for perhaps 3 to 6 months. So in this group now that are persistent out at 4 to 6 weeks, we still think it's likely that they have a reasonably good prognosis in terms of recovery, but we don't have the data specifically for that group yet to be sure.
Tem sido dito que a anosmia ocorre nos pacientes que têm formas menos severas do Covid-19, que isso poderia até ser um marcador de uma menor severidade. Mas será que isso que acontece mesmo? Ou será que aqueles pacientes que são mais graves, que estão com pneumonia, que estão com falta de ar, eles simplesmente não estão notando que também tem essa perda de olfação?
So that's a really good point. In the case series in patients with mild to moderate disease, the prevalence of anosmia is about 60 to 70%. Whereas in case series of patients who have been hospitalised with more severe disease, the rates reporting anosmia drop down to 20 to 30%. And so certainly there's a group in San Diego who have suggested that sense of smell or loss of sense of smell is actually a good predictor of mild disease. But I agree with the point that you made at the end, that what I think is going on is that this reflects recall bias in those patients who are very sick. If you're on a ventilator, you're not eating, you're not tasting food, you're simply more concerned with the severity of your breathing difficulties. And I think that loss of sense of smell in that group is simply overlooked or forgotten, because in many people they all will recover quite quickly. We've done objective testing in a group of patients with severe disease, and working with a team with Luigi Vieira in Sassari in Italy. And with objective testing, we found there's no difference in prevalence of loss of sense of smell with people with mild, moderate and severe disease.
De uma maneira geral, quando a gente vê pacientes com perda de olfato e suspeita de uma perda pós-viral, a gente costuma fazer uma investigação para eliminar outras causas, principalmente com exames de imagem. Nesse contexto agora da pandemia do Covid-19, você acha que a gente deveria fazer isso? O paciente vai fazer o teste para o Covid. Se vier positivo, há necessidade de fazer alguma outra investigação? Ou já está bom por aí? E caso vier negativo, se a gente deve fazer algum outro exame?
So we've just written some guidelines for the British Rhinological Society on this topic, because we've all realised we're going to start to see many tens of thousands of patients with COVID-related anosmia. So first, the correct thing is to try and establish the COVID status. And if we have a patient who we know has tested positive for COVID-19, who has anosmia but no other nasal symptoms, we feel there is no need to examine with endoscopy or to perform an MRI. For any patient that has persistent nasal symptoms associated with their loss of sense of smell, we feel that those patients should have an examination with endoscopy when it's safe to do so. And in some patients, if there are any other symptoms, particularly neurological symptoms or phantosmia or persistent taste disturbance, and that's true taste in terms of differentiating between salt, sour and bitter, we think there may still be an indication to perform an MRI in those patients, even though they have been known to have COVID-19 infection.
E agora talvez a pergunta mais difícil, né, em relação ao tratamento, né? o que a gente pode oferecer para esses pacientes em relação a tratamento? Existe alguma coisa que ajude? E em relação ao treinamento olfatório, né? Quando que a gente deve começar? E também como que a gente vai manejar esses pacientes, né, nesse contexto agora do isolamento social?
So, firstly, I think these patients are very anxious. They all want to know if their sense of smell is going to get better. And so reassurance is really important. We have used the British Rhinological Society, the UK ENT Society to publicise patient information leaflets and videos so that patients can access those online without having to see an ENT or a primary care doctor. We've also directed them to patient support groups, and in the UK we have two very good groups called Fifth Sense and Absent, which are both charities and support groups for people with anosmia. We are instructing patients to start smell training if their loss of sense of smell carries on for more than 2 to 3 weeks, because we know that 80 to 90% will likely improve quite quickly and therefore won't need to do anything. And again, those patient websites, Absent in particular, has very good instructions for patients to help them perform smell training at home. With regards to other medical treatment, as I'm sure you know, the evidence base for any treatments for post-viral olfactory loss is not great. But we've recently reviewed all the evidence and again tried to make evidence-based guidelines for treatments. So we are suggesting that treatments that may be considered as an option would be steroid rinses, topical steroid sprays only in patients that have nasal obstruction, and in patients where all their other symptoms of COVID-19 infection have resolved completely, having very carefully discussed the risks, perhaps to consider a course of oral steroids. It's very important that oral steroids aren't given earlier in the infection, as it can delay clearance of the virus. So you want to be absolutely sure that the patient is out of the high-risk period. And certainly I wouldn't consider steroids in the first 2 to 3 weeks of infection for that reason. The other things that we've considered as an option are either omega-3 supplements or possibly vitamin A topical drops. But the evidence for both of those is quite poor.
Muito obrigado, mas agora a gente não poderia deixar de aproveitar a sua presença para perguntar uma coisa um pouquinho de outro assunto em relação às cirurgias, né? Vocês estão realizando cirurgias eletivas, estão realizando só os casos urgentes? E como que tem sido o seu protocolo para garantir a segurança tanto do paciente quanto da equipe cirúrgica?
So we're planning to restart elective surgery next week, and it's been very difficult putting together all of those steps in place to make sure that both patients and surgeons are safe. And I think that those guidelines will evolve as we learn more about the disease. We've asked patients to self-isolate for 14 days before their surgery date, and we're performing 2 COVID-19 swab tests on the patient. Anybody where there is a high index of suspicion but a negative swab test will also have a CT chest. And anyone who is positive or has positive CT findings will be delayed. And in terms of PPE, we're using an FFP3 mask and a visor for those patients who we are confident are COVID negative on testing. But for any patient who needs urgent surgery who is COVID positive, we're using a PAPR respirator.
Okay, well, thanks a lot. I think it was great, and I think that our viewers are gonna really appreciate it. Once again, thanks for your time. I hope you'll be safe and hope to see you soon in person.
Thanks very much for giving me a chance to speak. Bye-bye.